Hi, everyone. Welcome to the Alzheimer's Association Dementia Care Navigation Roundtable webinar, Building the Business Case for a Dementia Care Program. We will keep the chat feature closed. Please enter your questions into the Q&A feature, and we will address as many as we can at the end of the webinar. I will hand over the presentation now to our Roundtable co-chair, Dr. David Rubin, Director of the UCLA Alzheimer's and Dementia Care Program, to talk to you more about the Roundtable, work groups, and our panelists. Dr. Rubin?
Great. Thank you, Nicole. If you can have the next slide, please. Okay, that's me on the left. And also in the audience is my colleague, co-chair David Bass, who is Senior Vice President and Senior Scientist at the Benjamin Rowe Institute on Aging. Next slide, please. Yeah. So today you're in for a treat. This is really going to be a lot of fun for everyone. I have had a preview of this, and I think people are really going to enjoy it. The lead authors and the developers of this module essentially are John Sawyer, who is a neuropsychologist and co-director of the Center for Brain Health at Ochsner Neuroscience Institute. Gary Epstein-Laval, who's a distinguished medical scholar at the Education Development Center and professor of psychiatry and human behavior at the Alpert Medical School at Brown University, and Michael Brown, who is the director of the Future on Aging team and the Alliance to Improve Dementia Care by the Milken, under the guise of the Milken Institute for Health. And these folks have really been working at this, and they're smart, which is really good. Next slide, please. There we go. And I'm going to turn it over to Gary, who is going to introduce the white paper.
Thank you very much, Dr. Rubin. Thanks for the introduction. Thank you and Dr. Bass for your leadership. It's a privilege to be working with you and with John and Mike. And this white paper has been a work group effort. So thanks to the full membership of the work group and also to the authors who worked with John and with Mike. And as a first step in our working group, John led us through an accounting of value, including how to define value, how to measure it. And he'll describe aspects of this as he walks us through the white paper section. And my task is to remind us all about the problems that we must address. So as you see on this slide, notably, the population is growing. Few health systems offer true comprehensive dementia care. Many places where comprehensive dementia care exists, it's due to research projects or pilot initiatives that were funded by philanthropy, all of which can have challenges of being self-sustaining, especially in a strictly fee-for-service model. But the financing view is changing. There are longstanding questions about billing in a fee-for-service environment being unable to fully cover costs. This view does not account for value upstream and downstream, and historic metrics have not been able to capture value added. So it's important, and our work group did this in the round, to take a more careful look at both the fee-for-service model and then value in a more expanded way. So next slide, please. This slide, specific to fee-for-service, shows some of the barriers that we're all aware of. There are not billing codes for every type of encounter. Reimbursement often doesn't cover time spent. And while there has been some success in fee-for-service using care management coding, it's complex and requires training to navigate through that additional coding. So the white paper was designed to help health systems take a broader financial view for how to make comprehensive dementia care a sustainable venture, including both fee-for-service and other payment models. Next slide. The CMS Guiding and Improved Dementia Experience model, or the GUIDE model, along with some innovative health systems, are taking a wider view of value. In these models, gains in quality of life for people living with dementia and their family caregivers are the prioritized goals, And these goals are attainable, looking at cost savings through fewer emergency room visits and shortened hospital length of stay. And for a health system to commit to dementia care improvement, it needs to see value added system wide, directed at clinical service delivery, at operational efficiencies, and at cost savings. And with an integrated population health strategy incorporating all of these tools, a health system can be poised for win-win, for better care and improved quality of life without increasing costs. And with that, I'll hand over to Dr. John Sawyer, who will walk us through the white paper's content. Over to you, John.
Great. Thank you. I appreciate it. And so what I want us to kind of think about today is, the difficulty in creating and sustaining and scaling dementia care programs is fundamentally kind of rooted in a value equation. And there has been, for most clinicians, including myself, an attitude of bemoaning the complexity of how you figure this out. And what we wanted to be able to do is to instead empower clinicians and health systems to kind of actually own the complexity. And once you own the complexity, once you understand it, then you're able to decide what you're going to do with it and how you're going to start, sustain, and scale your dementia care program rather than assuming that it can't be done. And the way we divided it was really into 5 kind of modules. We wanted to give dementia clinicians and health systems some way to reduce the complexity and kind of break it up. And so we're going to take a look at what do you do first? What are the next few steps? And then what do you do towards the end? All of this is designed to help everyone hopefully avoid all the mistakes that I made and other clinicians made in terms of starting and building their dementia care program. So we can go ahead and take a look at number 1 in terms of kind of analyzing kind of current state. And obviously it makes sense anytime you're at the beginning of something, the question is, well, where are we? So that way we can know about where do we want to go next? And so the big part of any kind of designing a dementia care program is to understand what is the kind of landscape in your organization. What is the population of dementia patients in terms of volume, in terms of type? Where are the access points for these patients? If you have 30 dementia patients or 30,000 dementia patients, it's going to be different. What are the demographics? Is this rural or is this predominantly urban? What's the care utilization of patients with dementia? Are they using it a lot, underutilizing? And the reason why you're kind of wanting to quantify your dementia population is that it helps you to kind of size up, are you able to meet the need when you later decide to design what kind of model you're going to build? It's really important to understand as well, who are all the collaborators, who are all the clinical entry points to dementia patients? Is it neurology, psychiatry, primary care? Is it, what does that look like? Because these become people that are not just your patients, your customers, but also these providers, these specialties are your customers, because they're people who oftentimes need a lot of help. And that's also really important to kind of catalog and understand what data systems do we have in place that we can get all this information that I'm kind of sharing with you. Some places have really good built-in data systems, others don't. Oftentimes, many clinicians don't even know. And so that's kind of where you want to begin. And part of this is just kind of building the how many, how much, who, all of that. And then when we get into the second part of understanding and kind of identifying value metrics, it's critical to take a step back and recognize as a clinician, frequently we are starting, most of us have not gone to get MBAs. Our MBAs are like trial by fire. And so you want to assemble a team of people within your organization that are in different departments. So trying to understand which department, it's finance, it's a revenue cycle, who owns and can give us information around what is a couple of questions. So the first is, how is value actually determined? Is it just how much revenue you bring in per year? Is it how much revenue per RVU you produce? Is it a fully capitated model where The health system assumes the full kind of risk of the patient. So really getting very clear about how value is determined for clinical programs. Because if you don't know that, then it's really hard to kind of move along forward. And then to understand what are those exact metrics, because some metrics can be very different depending on what your health system or your organization values. And then that way you kind of then get a menu. Like I think of this like a menu of value metrics. Frequently, clinicians only think about RVUs because it's the main thing that finance people track clinicians in terms of their productivity. But there actually are like multiple ways to think about value other than relative value units or RVUs. And so I would want you to be able to zoom out and talk to lots of partners, whether it's in your population health department, billing and coding. Like, what do lots of programs in your organization use to determine, to track, to document their financial value? And then it's very critical to kind of factor in a lot of this data. If I could give any of you all a piece of advice around getting the data, the spreadsheet they're going to send over will be like you're going to like 3 different iterations before you get to like, oh, that's the real data. Like it takes some time. It's also really hard to figure out, what our health system is using now and what does our health system want to use in the future. Because you may decide on a certain financial metric, but your health system is thinking, hey, 2 years from now, we're not going to use that anymore. It's also important to understand like where they are and then where do they want to go. And then when we go into the third part, is kind of reviewing the kind of care model type. So once you understand what your kind of financing and value model is, think of that as like your engine. That's like your financial horsepower. Okay, so what can we, reasonably, how are we going to like, what can we reasonably bill or produce in a way to then support our program? And from that, then you kind of start to think about the model of care that you might at least initially be able to design. For us at Oshner, we had to start with an intermittent consultant model. And that's where we followed up with patients initially and then as needed. And then over time, we're able to have a co-management model where we're able to follow patients, panels of patients monthly in partnership with primary care. Other programs, like in a fully capitated system like Kaiser, might have you may have a dementia care program and they assume total care, like they're the principal care home for these dementia patients, where it's like they're like the primary care place for it. And so these different types of models are cost differently and also have different ways in which they track, measure value. Other ways to think about care model types is not just how many services you're going to provide, how frequent, but also like what is the panel size? So care manager to patient ratio. Are you going for a very intense program where a care manager might be meeting, twice a month with a patient for an hour, or is it a lighter touch? Like what kind of patients are you going to see? And then from there, once you kind of know what the patient panel size is going to be, then you can all of a sudden start to simulate some like financial metrics around that because you kind of know, okay, we know what the staffing needs to be, we know what the value sources we're going to use, and then we can start to create some assumptions or projections from there. And then when we get into our kind of creating a credible program analysis, like many people will say, budgets are just projections and who knows what's going to happen. And so it's really important to recognize that you're going to have to kind of create a pretty clear list of what's our upfront cost, what are we going to use in terms of revenue in, and you want to think about revenue both in terms of direct patient services, like can you actually bill for care management, like with a guide billing model, or is it something that's going to be kind of indirect, and it might be that your the kind of services that are ancillary, like when you order imaging studies or labs, like part of that money is going to be tracked in terms of like downstream revenue. Like how are you going to pull in and track revenue? Another option, of course, would be if your program is able to save money, can you then like apply that in a way that shows that we're saving money per member per month, and all of a sudden your program value can be more easily quantified there. So I'd want you to think about the program analysis in terms of the cost of the program, and then what are the financial value sources, both like money in and also ways to save money for this patient population. So you think about it in like two different funnels. My experience is that a big game changer for dementia care programs is that it's really hard to fee for service your way into sustainability. And what I mean by that is you're not going to bill so many codes on Medicare that's going to pay for the program. Instead, what generally happens is that a program has a lot of value in terms of its ability to keep patients out of the hospital unnecessarily, a value to keep patients out of the ED. It reduces time to nursing home. It improves throughput for other specialties who are not having to see dementia patients because they're being followed in your program. And so from there, there's an actual calculation like, hey, if you had 110 patients and you knew that you saved, they were like half as likely to go to the hospital. That's how many hospitalizations does that save? We know that cost, and you can attribute that back to your program in terms of value and savings. Of course, doing that means your health system is really invested in value-based care, not like in a fee-for-service model. And so it's important to really understand what are all these different levers that we're going to use, because direct program revenue is really easily trackable. Like it's just you have a provider like me and you bill services. Cost savings generates a lot more in terms of potential financial value, really challenging to track over time from a data analytics perspective. You kind of have to have more robust systems in order to do that. And I think Miss Letitia, there you go. You're okay, perfect. And so there are a lot of different ways to look at and track value. And this is why part of why we wanted to build this out. We wanted clinicians to kind of zoom out and not think just about what their finance partners might be telling them is only one way. There may be like 20 different ways for you to look at value. And so that's really the whole goal of these modules, kind of 1 through 4, is really about how do you go from where you are, how do you identify what are the main financial value metrics in your organization, how does that inform what kind of care model you have, and then how do you have a credible program analysis so at the end, a year later, you can say, hey, like we were right, we were wrong, and then what happens next? And then we can go ahead to the next for Mike.
Thanks, John. Hi, everyone. I'm excited to talk about the Dementia Care Financial Model, which is Module 5 of the paper. And we thought it was really important to also own the complexity. So I love John's continuous saying of owning the complexity and understanding, yes, healthcare financing is complex and dementia care is even that much more complex. He was spot on to really look at the value drivers in value-based care because as you'll see throughout the module, it is small in direct revenue of billed services, but if you're in an overall program that looks at keeping healthcare costs down outside of ED or admits and increasing risk adjustment, you start to see much broader impact there. So within this model, it is a planning tool. It is not meant to make investable decisions off of, but it's good to apply to your organization, and we make some assumptions across a 24-month period. And so I have the fun lift of presenting the Excel sheet and diving in. I'm going to share my screen and really provide a nice flyover. I like to joke of the Excel model, and so I'm hoping to rival Charlie Pugh's flyover of the Super Bowl, which was pretty cool, and I think this one will be just as exciting. As we look at the financial model, you land on your cover page, and then I'm going to go through the tabs following it to give you a high-level overview, really to give you an appreciation of the mechanics of how the different tabs are working together, and so you can understand the formulas, but then encourage you to click in to the model, edit it with your own program so that you can track and monitor and make the case to continuously invest in your dementia care programs. If we look at the workbook overview, this is where the 6 tabs are highlighted with a little description and picture so you can get a feel for everything in this workbook. It's high level right now, so you might not be able to read everything, but it's giving you a feel for what's in the pages. The edit cells and the formatting is important when you're looking at different type of models. So a standard formatting looks like yellow cells with the blue text is editable, and that's an assumption that we've made. So we've made that assumption through industry analysis, through case studies like Dr. Sawyer's at Ochsner or Dr. David Rubin's, and we've applied this to this model. But here you would be able to edit those and use your own numbers to get it more tailored towards your organization. We then look at a summary dashboard, which is populated of all this information, and the billable visits and amounts. So we've taken a 24-month schedule and applied that to different patient severities, which I'll go into, about the rates you could potentially bill for each severity of patients. We've created then 2 program profit and loss statements, P and Ls. So here we have a guide model, P&L, which would be under the traditional fee-for-service Medicare patients, but then non-guide, which we're calling comprehensive dementia care management, CDCM. And so this is really important because although they might not be eligible for guide, it still makes sense to offer comprehensive dementia care, and you'll actually be able to see how much value creation you can get when you're under bundled care in a Medicare Advantage program. So that's our second P&L, and they look exactly the same. I'll show you how the guide model is a little bit more complex with the monthly tracking. And then we blend those 2 together in a blended profit and loss statement. So here we add up the revenues attributed to both the guide model and the comprehensive dementia care program, and we add up the expenses on both program. And then lastly, we present a case study on value-based care of what was that risk adjustment seen and that cost savings after a 12-month period, which Ochsner Health contributed. So I'll jump into the following tabs. The next tab over is the summary dashboard. This might look foreign right now, but I'll explain how it's populated with the tabs behind it, and then we'll jump back into this. You can see that there's no yellow editable cells. So here you're not meant to put new information, but you'll be able to see your cumulative profit and loss across both programs, your monthly volume as you recruit patients. You'll see this growing. The general rule of thumb here is the faster you're able to recruit patients, the faster pathway to profitability. So we've taken some assumptions here that about 350 in each stage up to 24 months. And clearly you'll be able to add in your actuals. And it's not going to be a straight line. We know actuals are going to have fluctuation. Moving to the monthly billable visits and amounts, I'm going to zoom out here so you can get a full appreciation for everything on the sheet. It looks complex, but once you understand how it's working, it's a little bit more simpler. On the orange, we have the guide model. So that's our guide program, billable amounts. And then in the blue here, we have the non-guide comprehensive dementia care. So it's split into 2 on this sheet. You'll see these 5 yellow schedules here. That's a different 24-month schedule for our different patient severities. So as part of owning the complexity, I'll go into how many different types of patient severities we have and different billing codes. And within the guide model, it's actually 10 different types of billable rates based on your patient. So in our member rate table is where you're going to collect all the different CPT codes that you could bill for that program. And here we've collected a few for you. We've collected the EH and ENM codes for level 4 and 5 as an initial visit, the cognitive assessment and care plan code, and then the 10 different rate codes of the guide model. So there's 5 different complexities: mild, moderate, and severe, with or without a caregiver. That's 5. And then they added more complexity to say within the first 6 months, we're going to pay you a higher rate because you're newly onboarding a new patient and have additional time with them. And then in month 7 plus, we're going to lower the rate. So right there, you need to keep track of 10 different billable amounts based on who the patient is, what their caregiver status is, and where they're at in the program. So you can see the complexity starts to add up. As we look down the 24-month schedule, if we take one example and look into it. So for monthly dementia care and with a caregiver, we thought, what would be the best case scenario for 24 months? Could we give an average patient visit of 24 months? And since they're lower complexity, we did not see need for follow-up visits. And so we just did one monthly billable guide visit. But since these are yellow text, I can come in and I can add new visits here and edit this. And if I did have a follow-up visit, it would grab from the rate of the follow-up visit and add this down. And then it's important to average these over time. So if you click into the cell, you can see that now we're averaging the first 6 months of the patient's experience here. So this is how we were able to get a general rule of thumb of what a patient at different severity levels we could expect. And this is why it's a planning tool. It's not an actuals tool because every patient is different. As we move up the severity level into more of the moderate and severe, we anticipated seeing more follow-ups based on more severity needs. So within severe, we've added additional follow-ups and 2 follow-ups within the first year and 2 in the second year. And then with caregiver and non-caregiver, we've added additional follow-ups. So you can see as they get more expensive, their billable rates are increasing because of the increased complexity. The same rules apply for the comprehensive dementia care schedules. Here within these billable codes, we included the E&M codes as well as the cognitive assessment and care plan code that you can bill outside of Guide. Guide has that bundled in. And for these monthly visits, we're using the chronic care management code. We've also included the principal illness navigation codes if that fits your organization and your needs. And then we wanted to reference some other codes that could be available for you: community health initiatives for community health workers, caregiver-focused education tools, something that allows you to emulate the guide model, but not be in that bundled care program. Now, non-guide is slightly simpler because it doesn't have the 6-month change in rates. So here we have our 5 types across 24 months. And we've added sort of a best case scenario. What does those billable visits look like? And we've anticipated an annual visit, a cognitive assessment and care plan, and then monthly care maintenance visits. And if I need to add, again, additional follow-ups because I have that already planned in, these are pulling the rates. And so you can customize this to how you need, and you can see how it's then changing and influencing your average across here. These are averaged across all 24 months because you don't change the months. So this is important to then give you your billable rate times your volume. In the next 2 tabs, the profit and loss statements, we build how much volume we anticipate to have and the severity mix of each program. So now moving on to the profit and losses is where we're going to talk about the 2 main drivers: the revenue drivers of your billable amounts times your volume, and the expense drivers, which we are using is mostly staff headcount and cost of the clinical staff. So zooming out here, I know you can't read all this, but it will give you an appreciation for the table. In the orange here are your revenue drivers. So this is your patient severity and your volume of patients you're able to recruit in the program. And then we multiply that by the average monthly billable rates to get your monthly rates across the 24 months. And the blue here is your cost drivers. So here we focus on the clinical team. I'm going to jump in a little bit here just to give you some key assumptions and think through how this works. And again, the guide model P&L and the comprehensive dementia care P&L are the same, so I'm not going to go as in depth with the next model here. Patient severity mix is critical. So as you heard before, there's really 5 different severity types: the mild, moderate, and severe, with or without caregiver. What we're seeing from practice experience is about 85% fell into the mild and moderate with a caregiver, 15% fell within the other 3 buckets. And so this is an assumption here. We would love to test that assumption with what you're finding and compare and contrast this, but we've chosen to go with this rank here. As you look into volume of recruiting monthly patients, this is called a waterfall schedule. So some of the complexity that CMS likes to do is change monthly billing. And so one way to track this is to have a monthly cohort, where for each cohort, you track them over time and keep them within month one cohort, month two cohort, and so on. So here our key assumptions are new patients recruited per month. So if you're just starting out the program, you'll see we expect 21 patients to start and then 15 new patients per month. As we get better at it, we can maybe recruit 16 at a time. But then we're also going to need a retention assumption or a touch point assumption. So part of the guide model is that you need to make monthly contact with that person. And so you're not maybe going to get 100% each time. And so we made an assumption that you're going to see a retention fall off the longer the person is expected to stay in the program. As you look at the waterfall, the way you would read this is that month one, you have your 21 people from month one and 100% retention in month two. And then you also started month two recruitment. So now you have 15 new patients from month two plus your month one cohort brings you to 36 patients. And so you can see as we get past 6 months, now we're adding up those that are in 1 through 6 months and getting billed that first code, and then those that are in month 7+ getting billed that second code. And so that's why you're able to track when did the person enter the program, what monthly cohort are they in, are we seeing a retention rate in 1 month versus the next, and it really gives you better tracking ability. Then we look at patient mix by severity. So now we're pulling our assumptions of the severity table times our volume to get how many patients are within each severity segment here. So again, 10 different patient types based on month, severity, caregiver status. We multiply that by percentage, and this allows us to give estimates to who might be in those buckets. We then multiply that monthly by the billable rate that we calculated in our last tab. So we just went through, we did the work of what does a great 24-month billable average experience look like, and now we have our codes to multiply with our volume to get our revenue. So that's how you get your monthly revenue in the guide model by monthly cohorts. And that's your revenue driver. Looking at the blue here is your cost drivers. And so you'll see we have a section overview of each section to read into and understand what each table is looking at. The cost drivers direct to the program are really your team, compensation, and FTE attribution and allocation. So you want to be efficient, you want to be lean, you don't want to scale too much headcount in the beginning, you want to try and scale as patient volume increases. Here we applied about a 50-50 split on team members attributed to the guide model and team members attributed to non-guide. We have a program manager, we have dementia care navigators, which may be different types of clinical types. We've referenced a licensed clinical social worker. We looked at about 100 patient caseload for the care navigator. We look at an MD attributing some time, but mostly this is an NP-powered model. And then if available and attributed, we would encourage a clinical neuropsychologist and a pharmacist. So their annual compensation amounts multiplied by their attribution to this program will get the monthly cost. And then the monthly cost times how many headcount you have gives you your total monthly schedule. So moving a little bit quicker just because this is kind of general applicability here. Depending on how many patients under management you have, you want to maybe scale up. And so for this, the real dependent factor is the care navigator needs to scale up. As you get over 100 patients, you would add another care navigator here. So that's your cost side, and your profit and loss adds up both revenue and cost. So as we move down here, you can see now we're in the monthly profit and loss summary. So we're adding your billable amount, which we pulled from the top. We're adding your expenses now, which we talked about with the cost of the team and the allocation to get operating profit margin. In this model, we use a standard 15% overhead. It's important as you are the administrators of your program to think about how your specific program is profitable as a standalone before you add shared services costs and other financials. A lot of times the finance team will like to put different overhead costs into your program. So you would do it with and without the different shared services costs as well. These graphs here then look at the monthly profits, so month over month. Within these assumptions, we're looking to turn monthly profitable around month 10, you can see here. And then cumulatively, you're seeing this J curve of profitability. So you have high investment up front to build the teams while you're still building your patient volume. And then as patient volume grows, now you're seeing profitability by month 18, 19 in this case. And so the faster you're able to do patient recruitment while you're keeping your costs low of heads of team staff, the faster you're able to see profitability. The P&L for the CDCM looks the same, so I won't go too much in depth with that. It is slightly less complex because you don't have the month 6 to month 7 rate change, so you don't need to do the different billing codes there. It's still important to capture your severity, so we use the same assumptions on the guide model and the same assumptions for non-guide, but maybe your severity is different in the Medicare Advantage population that you'll want to change this and make this unique. We still use the same assumptions around the average growth. And here we do monthly cohorts just to see the retention and the fall off, but we don't need to compare difference between month 6 and 7, as I mentioned. And it's working the same as the previous P&L, going towards that number of patients we've recruited times the severity mix times the rate of each severity segment. And here we just have 5 that we built on that previous tab. And so that gives you your monthly amounts. And then cost drivers, we've mirrored the same team that we used on the guide model. So we've used this general 5 different types with a growing care navigators as we scale for different type of volume growth, and use the same attribution split, usually 50-50 their time between models. So that looks the same. And the overall monthly profit and loss looks the same. You add up the billable rate from the top of the revenue and then add your expenses down here. And so you'll get monthly cumulative profit and losses. And then we do this for per member per month by dividing the totals by the total patients managed per month, and give you your graphs here. And here we see you're making a little bit more money on the non-guide program. The next tab is your blended monthly P&L. So that is a simpler tab which adds the profit and loss of the 2 programs and combines them. So the green here is a link to other tabs within this workbook. So you'll see that these green cells are linking to the guide P&L, and the other cells are linking to the enrolled CDCM. So that's your revenue from both programs, your cost from both programs, and then you're able to track total, what am I expecting to reach profitability? And in this case, between month 18 and 19 should be cash flow positive. And then we break that up per member per month. And so you'll see direct cost is slightly skinny at 182,000, but as I show you going into value, that's where you're really starting to see impact of these dementia care programs. So we thought it was important to give you a case study on value-based care, and here we use the Ochsner care ecosystem compared to a control cohort. So I'll zoom in a little bit so you can see what we're looking at here. The case study compared to 121 patients in the intervention program and 121 in the match controls. They, as any match control does, look solid at the same illness burden score, average age, and disease complexity. And within 12 months, the Ochsner care ecosystem generally kept total cost of care stable. So generally stable over that time, whereas the non-intervention arm match cohort saw an increase of $500 per member per month. And so that adds up when you're looking at recruiting over 300 patients. So that net benefit is $475 per member per month, which can be attributed to cost savings. How we would look at value drivers on revenue is risk adjustment scores. So a rule of thumb we're using here is that for every 0.01 improvement in risk adjustment, you could expect $8 in revenue. And so the program saw that compare and contrast, saw a net benefit of 0.245 in risk adjustment, about 0.25. Times that by 8 is about $200 per member per month in risk adjustment. So we added that up down here. You're not likely to see program impact within the first 12 months. So we've grayed out the first 12 months, but months 13 plus, we've started to see impact. And important to note that this is non-guide. So although you're you need to turn away patients from fee-for-service guide if they're in Medicare, you're actually seeing a lot of value drivers of offering similar programs on the Medicare Advantage side. And so this starts to add up here as you multiply the $476 per member per month across the next year. And so we've added up the potential risk score improvement and savings, which you can see, as I mentioned, 180,000 for direct revenue, but nearly 700,000 in risk score improvement and 1.6 million in savings to the system. So that's where the value equation on the value-based side starts to really add up. Lastly, we provided a summary of different type of templates. So recognizing that finance teams report things differently, we thought it'd be important to show you other ways to capture cost. Things not included in this operational model would be one-time startup costs. So if you're investing in new space, marketing, different type of startup costs, that would go in there, and then indirect costs. We see a lot of value being derived from the diagnostic services, the lab services, procedures, and infusions based off of the population, but did not contribute them directly into this program. So those would be additional value drivers. So if we go back into the summary dashboard now that you'll be experts in, you'll see that we have our monthly profit and losses of our blended programs. We have our patient volume increasing. This is obviously a steady increase for assumptions, but would change with your own numbers. And then we have the value-based performance metrics. So you can see here the power of value-based care, where within this model, only about 10% of direct revenue was attributed to those billable services, whereas the savings and a risk adjustment looked at close to 90% of total value to the system. It would be important to track the guide and the non-guide membership amounts, the head count, and then patient severity. Are you seeing mild and moderate patients with caregivers? Are you seeing a lot of non-caregiver patients need services? Would be important to track. And then using per member per month calculations, you can compare and contrast different types of programs. So we've offered the care ecosystem benchmarks as a potential comparison. So thanks for following along there. I'll stop and share. We'll jump
Before
into
you stop,
Q&A.
I was going
I
to
know
real
that was a
quickly.
lot to cover quickly, but I thought that served as a good basis for you all to understand the mechanics of the model, and we hope you take it for a spin yourself and learn how you're applying it to your model, to your organization.
Apologies, real quickly, can you share your screen one more time? There's a specific question in the billing and coding worksheet around the guide and non-guide billing codes. Which one are standard outpatient billing codes versus guide specific? While you have the spreadsheet, do you mind just talking through that a little bit?
Guide specific. So within guide, we understanding cannot build a 99483 cognitive assessment care plan. It's meant to be covered under the guide model specifically, as well as some of the principal illness navigation code or different care navigation. It's meant to be comprehensive into the guide model. So for the non-guide, that's where we added additional codes. So you could bill, in this case, chronic care management plus a cognitive assessment care plan plus follow-up E&M codes.
Thanks so much. I will share my screen now again. And we will go back to our presentation.
Yes, thank you.
Real quickly, before we shift to Q&A, I wanted to say thank you so much to our generous 2025 sponsors of the Dementia Care and Navigation Roundtable, without whom the work that this team has done would not be possible. So thank you very much to our sponsors. And with that, we will shift to the Q&A portion.
Yeah, let me get started.
Go ahead, Dr.
Uh,
Rubin.
the first thing that comes out of my mouth is wow. This is just so impressive. As someone who has been in this space for a long time and um, creating spreadsheets that compared to this are like toddler tools, um, that this is so impressive, this work. I specifically would have liked to have this instrument at several points. First of all, when we were just forming the program, before we even took it to anyone, to see our program had legs, did it make any sense? Second, I would like to have had it when we first went to the administration to ask, can we get it started as a pilot to see the potential? And then the third time I would really like to have had this is when we had to expand the program, particularly for guide. We followed a lot of these principles, but much more rudimentary. So, a huge tip of the hat and thanks to these three people who created the model that I would have dreamed of. So we can open it up to questions. Nicole, do you want that in the chat, or do you want people to just raise their hand?
They can enter that in the Q&A feature. Because we're
Ah,
going to post this on the Roundtable webpage for people to watch later, we did limit the interaction on the webinar, so apologies for that. I'm getting a lot of compliments to the team as well via Q&A, so I concur. It's been wonderful work that this Roundtable work group has done. One of the questions that is similar to what you were talking about, Dr. Rubin, is really around who actually fills the spreadsheet out, who are the initial team members, and do you use this more as a collaboration with the finance team or having it ready for the finance team as a sort of a advocacy tool?
Yeah, I would absolutely not just share it with the finance team because they're going to look at it and tell you how wrong you are. Like that's just kind of how this happens in any kind of health system. The biggest thing is for people to develop a relationship with their finance team and sit down and talk about here's a model that we see. How applicable is this to what we currently use in our institution when we think about starting a new clinical program? Remember, before they hire any physician or any nurse practitioner, there's a pro forma that they have to do, like, okay, how much does this person cost? How much money do we think they're going to generate? And so, what does your institution use for that? And I would think about that as like almost some degree of synergy. And the other piece is sometimes if you aren't regularly talking with your finance partners and you email them and say, hey, can we meet to talk about how you track our financial revenue? That's probably not going to occur to them that you're just curious. They're probably going to want to know why you want to know. And so then it's really other part is critical to say, here's the why behind us having these conversations. And like that's kind of the change management piece of it. So talking with them, sitting down, and then what's the journey with them around like using this tool? What does their tools look like? And then how do you kind of sync them up?
Thanks, John. Another question is really around the care model. Do you start thinking about the care model from the perspective of the models that you have in your system today, more from a financial perspective, or do you look at the evidence-based models out there? How do you sort of know where to start? Dr. Rubin, I don't know if you have a perspective on where to start with the care model, or John.
okay.
Oh,
So the
Dr.
care model is really clinical. Care model is clinical, and what works at your own institution. What kind of resources did you have? There are at least seven evidence-based care models for dementia, comprehensive dementia care. And we've spent a lot of time helping institutions adopt these. But for each institution, it's a personal choice. There's no one model that I've seen that works everywhere. So it's really and the National Dementia Care Collaborative has actually a tool that helps people work through which model might be the best. And I can share that with you, Nicole, and you can distribute it.
Great.
There was a
And I
question though,
go ahead,
Nicole,
Jeff.
that someone had about dementia care impacts other chronic disease management and value programs. And that's a very critical question. So if you're in an institution that has a lot of value-based care programs and your dementia care program is looking at tracking value, like, hey, are we saving money? Are we reducing admissions? The hardest part of that is attribution, like how much did your program do it versus the chronic heart failure program versus the case management program. And so you have to be really kind of thoughtful about who you're meeting with and what your population is, and then how do you have a comparator population. So like one thing that we're thinking about doing here is we have a fully capitated 65 plus model for geriatrics. Well, then let's take a subset of those and manage them and compare them to dementia patients who are unmanaged in the same group. And what does that look like? But you would have to do that on a different disease state, like heart failure. For this one attendee got a question, you would need to have like a certain number of heart failure patients with dementia, and you care for half of them, and then compare their cost and performance to the other half. Like that's kind of how you would have to think about analyzing it.
Spreadsheet, with broad assumptions. And I know you mentioned the fact that people, will need to modify it to their particular setting. When you look at case intensity, were there considerations in that around whether a patient is or is not receiving treatment and how progression may be slowed by that? I don't think so, but I just want to make sure what's
Yep.
behind the case intensity.
No, and I would ask everyone when you think about dementia care management, it certainly has a huge value add to patients who are on anti-amyloid therapy. This is largely like our assumptions were largely around patients with moderate stage dementia forward, sometimes mild dementia, but these are patients who are none of them are on anti-amyloid therapy. And as soon as you add in the anti-amyloid therapy as a value part, you're going to have to think about like, does your organization want you to do that, or do they want to use that value for like the behavioral neurologist and the anti-amyloid therapy clinic coordinator and nurse? Does that make sense? Like there are a lot of different hands in that pot, so to speak. And so you have to think about like, to what extent does anti-amyloid therapy, is it just to offset the program cost, or do you think the program helps optimize patients and caregivers like use of anti-amyloid therapy? I think it does. But you'd have to kind of like get with your team about what that looks like.
Thank
Yeah,
you.
the other piece I'll add on that is the care navigation roles. So does the dementia care navigator touch therapy management, or would that be another navigator? So really having them focused will increase the capacity.
Great. Just perusing the questions. I don't think the model took into consideration shared medical appointments specifically. Is that correct, John and Mike?
When you mean shared, but help me understand what that term means to the Cleveland Clinic, because I don't quite know. Like, is that like, hey, you work in different clinicians work in different places, or tell me, or they have different? I'm wondering, what that term is there, I guess.
And I'm not aware. Dr. Rubin, do you know Cleveland Clinic's model of shared medical appointments? And we can't have the audience chat, so I'm not sure there. So I don't
Um,
believe it's based on that model.
no, I don't think so either. I mean, there are some models where they actually have more than one patient or caregiver or whatever in this situation, so they can bill for more than one person during one visit. But none of the models that I know are doing that.
Great. I think we've gotten to all of the questions.
There,
Let me
there's
just,
there's one that was asked in a couple of different ways by Ian Kremer. Thank you, Ian, about the flexibility for the user. And Mike, I don't know if you could speak to how the individual health system would be able to make its own assumptions about course of care, whether someone is on anti-amyloid treatment or not. Sort of their assumptions about there being potentially lower severity patients for longer time.
So we factored in, if you think about the way this is, it's the first 2 years, and it was mainly factoring in what you think the blend of patients are coming into the program. But it's not showing their change over time in terms of going from mild to moderate. And I would advise people not to do that because what it means then is that they could all stay in mild, but more than likely they're going to progress at some point, and that would just mean like extra money, not money you thought you were going to get, but didn't because they didn't progress. Does that make sense? And so I think it makes more sense to build your model based on like who you're getting in. And that's kind of going to be the fee you get for the foreseeable future. And when they do change from mild to moderate in guide, for instance, then that's like a nice surprise for your program and not like you expect it to go to moderate in 3 years, but really it took 7 years. Does that make sense, Gary?
Yep, does to me. Hope it answers Ian's question.
That's great.
Thanks, Gary. Well, panelists, any final thoughts you would leave our audience with before we close? I think everyone did a wonderful job. All right.
Thanks,
Well, then I'm
everyone.
going to
I will
say,
say, own
oh,
the
go ahead.
complexity, download the model, get your hands dirty, click into it, use it, and we would love to hear how it's working for you all, what your assumptions are different than ours, and learn from you all. So thank you so much.
Thank you, guys.
Wonderful. Well, thank you so much to our panelists again and to our attendees for joining the webinar today. We will have the link to this recording posted on the Dementia Care Navigation Roundtable webpage in the near future. I will send that out as a follow-up, but also in the meantime, you can email dementiacarenavigation@alz.org. Again, Dementia Care Navigation, all one word, @alz.org for more information. This is our roundtable email address, and I can respond to that. And we hope you have a nice day, and thanks again for joining.
Take care. Bye-bye.